So hi, everyone. Welcome to our SCAI Conversations in Interventional Cardiology series. We're going to be talking about a brand new SCAI Expert Consensus Statement on the management of calcified coronary lesions. My name is Alexandra Lansky. I'm professor of medicine at Yale. I am the editor-in-chief of JSCAI. And it's really my pleasure to be with wonderful friends and colleagues. Binita Shah is Associate Professor of Medicine at NYU Langone, and she is the chair of the consensus. Robert Riley is the co-chair of the consensus, and he is the cath lab director at Overlake Medical Center in Bellevue, Washington State. And my good friend Danielle Chamie is the director of the invasive laboratory at Yale University. And I just want to welcome you all to this conversation, and it's great to see you. So I'm going to ask you, Binita, if you don't mind, to kick this off and lead us through just sort of the high takeaways, high level of the consensus.
So first of all, thank you so much for having us. We're thrilled to be here and to share what we've put together. A lot of work has gone into this over the last year or so by an excellent group of people, really experts in the field. So there were a few aims to this document. One was to outline the methods for identifying the various types of calcified coronary lesions. To review the different calcium modifying tools and provide practical tips when using these different treatment strategies, and to present an algorithm designed for addressing calcified CAD, and then to finally examine and summarize some ongoing trials and emerging therapies in the area. So when looking at identifying types of calcified coronary lesions, we have tackled all of the various phenotypes, including calcified nodules, long calcified lesions, CTO interventions, ISR, in-stent restenosis, post-coronary artery bypass surgery, the challenges associated with that, and do provide a highlight statement to summarize some of the key take-home points or some interesting things that we put into the document that we do think that everyone should know and is not necessarily something that is a common knowledge. And looking at the criteria for coronary calcified modification, we have asked our colleagues to think about the angiographic criteria, which includes radiopacities noted without cardiac motion prior to contrast injection, and then think about the intravascular imaging criteria, which really includes 5 points of maximum arc of calcium, 360 degrees, calcified nodules, or if there's calcium greater than 270 degrees and at least 5 millimeters in length, as well as vessel negative remodeling, which is defined here as the lesion EEL diameter versus the distal EEL diameter, and we'll show some examples of that. And then finally, the minimum calcium thickness if OCT is performed. Here are some of the examples that we give of 360 degrees of calcium, and we wanted to give examples using both IVUS and OCT so that everyone could see what these would look like by both modalities. Here's evidence of a calcified nodule. Here's evidence of a significant arc of calcium that happens to be thick as well, particularly noted on OCT, as well as a proximal and a distal vessel to demonstrate what vessel negative remodeling would look like. And then we wanted to then go on to treatment modalities for calcified CAD because it does pose a challenge due to the increased complexity of these lesions. And when CAC is present, you can have challenges, including stent under expansion, which could then lead to poor outcomes such as stent thrombosis and in-stent restenosis. And these are things that we definitely want to be avoiding over time. Some of the treatment modalities that we go through, semi-compliant, non-compliant balloons, as well as specialty balloons, including the good old cutting and scoring balloons, as well as some of the newer, very high-pressure balloons. Rotational atherectomy, orbital atherectomy, laser atherectomy, and IVL. What's unique about this statement, however, is that we don't just summarize what these modalities do and what are some of the data behind these modalities. Rather, we really go into we include consensus tips and tricks that we felt would be helpful for operators, a practical guide. So rotational atherectomy, orbital, laser, IVL, all of them have an associated box highlighting some tips and tricks on how to deal with safety and efficacy with these devices. And then looking at treatment modalities for calcified CAD, we also include specific lesion subsets as well, and include similar consensus tips for calcified nodules, CTOs, in-stent restenosis, aorto-osteal lesions, and how to deal with these particular challenging lesions with different treatment modalities. And as well as consensus tips for bifurcation lesions. And all of these tips that we highlight went through several rounds of surveying the group until there was a clear consensus among the authors on which tips to include. And then finally, we created an algorithm for calcified CAD. If there's angiographic evidence of calcified lesions, then we ask people to go on to image these vessels to look for criteria of calcium modification. And these criteria include arc, length, nodules, negative remodeling, and thickness of the calcium that we described. If imaging is not feasible or the imaging criteria are not met, we think it's okay to proceed with a non-compliant or specialty balloon, but if there's no chance that's going to be delivered, really just going on to atherectomy. And then once atherectomy is performed, really going back to imaging to see if there's any evidence of further need for calcium modification, or go back with a 1-to-1 balloon and ensure that there's full expansion. Now, sometimes we see calcium fractures on imaging, sometimes we don't. There are microfractures that can still occur. And so just because we don't see fractures on imaging, it doesn't mean that it hasn't cracked enough. And so we do recommend full expansion of a 1-to-1 balloon in 2 views when possible. Now, if the intravascular imaging criteria are met for criteria for calcium modification, we recommend atherectomy, IVL, specialty balloons, depending on the phenotypes. And some of these considerations are long diffuse calciums with or without nodular calcium would be best for atherectomy. Concentric, eccentric, or nodular calcium could be treated with IVL, and focal calcium could potentially be treated with specialty balloons. Again, finally, we want to look for fractures. If there's fractures, great. If there's no fractures, we want to make sure there's full expansion of a 1-to-1 balloon in 2 views, and then only proceed with PCI. Really highlighting the point that we want to make sure that these lesions are incredibly well prepared before the stent goes in so we don't deal with the stent regret. And then finally, we do cover some of the several ongoing clinical trials that are occurring all over the world with these various devices. The great news is that although we've been lacking data so far, there's a plethora of trials coming out that are comparing different calcium modification treatment strategies. And that may be helpful to us moving forward to determine a little bit more on which phenotypes would be best treated with which strategy or combination of strategies. So our final conclusion was that PCI of calcified CAD is increasingly common, particularly as our patients are getting sicker with more comorbidities, and they do have associated greater risks of adverse events, and that we highly recommend the use of intravascular imaging whenever feasible to determine the use of the calcium modification techniques. And we definitely want you to prepare the vessel for optimal stent deployment.
Thank you. That was a whirlwind tour. I think, as I reread the document, I have to say it's absolutely amazing. And you managed to really kind of, condense everything. It's beautifully written, I think, as you point out, all the tips as you go through the sections. So for the listeners, I just encourage everybody to go to jsci.org, download the document and read it because it's excellent. All right. Well, thank you very much, Binita, and congrats to you and all the co-authors. I wanted to maybe kick this off. You make the point that invasive imaging is really key, right, in treating these types of lesions. When we look at national rates of invasive imaging, it's like, 20%? I don't know that it's much higher than that in calcified lesions. I think it's really important to make the point again to our listeners that it's not just a nice to have, but it's a need to have. So I wonder if you guys could address that. How do we convince people that we really need to use invasive imaging to better treat our patients?
Yeah, I think there's two aspects. People need to know what they're looking at, and people need to know when they need to react to something. And that's not as easy as it sounds. It requires so much doing before we get a bit more comfortable, which is why one of the goals of this paper was to include as many imaging examples as possible using both modalities, so that if someone's an OCT user versus an IVUS imager, and then when to respond to it. Just because you see some calcium, do you do something? Do you measure how do you measure the lesion diameter properly? When do you have to be a little bit more aggressive versus less aggressive? Those are all I think difficult algorithms or steps to go through in our mind. And then finally, the ease of use. So I think the more we do it, the more comfortable we get with it, the more likely we're able to understand what we should react to and what is okay. This is what it should look like, and the patient will be okay. But also getting the teams used to it so that it's a lot quicker and it doesn't add time. That is a huge thing in a busy cath lab time. Love to hear other people's thoughts.
Daniel, I know we talk about this all the time. You've written about this, so what's your perspective on that?
No, I agree with Binita. I think, people need to see value in what they get from imaging, right? Otherwise, it's just opening a catheter, throwing it in, and not getting anything from it. And what I like about the document is that we have independent calcium scoring systems derived for IVUS and OCT that both have predicted stent expansion at the end. And what the document does is kind of merging both scoring systems into one major system that simplifies the algorithm and facilitates people interpreting the results and kind of reacting to the images and really understanding when they should actually prepare calcium more aggressively than just non-compliant or whatever balloons, and moving forward from there.
Yeah. I think one of the concepts, and I'm kind of, approaching this, as we do a lot of trials in this space, and we review a lot of angiograms. The concept of lesion prep versus vessel prep, I think, is an important one. Rob, I'm going to pick your brains on this one. We tend to be very focused on that lesion and preparing that lesion, and obviously a stent goes in and we want optimal results for that stent, but so many times we actually see that stent results are great, but then there's some residual, maybe there's a ring of calcium and that's been left behind. Can you tell us what your approach is? Should kind of having more of a holistic approach, I guess, is what I'm getting at.
Yeah. So again, thanks so much for having me, and it's a great question. I remember the days before, we can't use the term widespread, but before the days where intravascular imaging was used that often, and we would, as you say, do a lesion prep. We'd go in with the balloon. It inflates 1-to-1, great, looks okay, we move on. It doesn't, maybe I got to do something else. And we would use these very subjective, just sort of ideas about what we need to do for this lesion prep. Then we started using intravascular imaging, and you really realize it really sort of identified and brought home the point that, atherosclerosis is a systemic disease. It's not confined to a lesion. And one of the reasons that has been hypothesized that we have such high target vessel, target lesion failure rates is that we really don't treat the vessel, we treat the lesion. We leave behind significant inflow and outflow disease, and this creates flow perturbation that's going to increase the risk for stent failure, whether it's through in-stent thrombosis, restenosis, et cetera. And so that really helped us understand that it really is about vessel preparation as opposed to just lesion preparation. And that's why intravascular imaging is so key. It lets you know what are reasonable segments to land both stent edges what are reasonable segments that need further modification outside of your standard semi-compliant balloon, whether it's NC, specialty, atherectomy, IVL, et cetera. And that's really, again, to this idea of vessel preparation as just opposed to lesion. Unfortunately, we just don't get that, with angiography alone. That's been shown time and time again. We're wrong more often than we're right in terms of sizing, in terms of length, in terms of quantification of calcium. I remember, enrolling in some of these trials with devices, for significant calcium, and they'd have angio criteria, right? You're like, great, yeah, we're going to enroll this person, boom. But then they'd have this imaging sub-study, and they'd say, hey, now listen, if you put the imaging catheter down, you might get them out of the study. So is this one that you want to do in the imaging sub-study? And we all realized it's because we have no idea what's going on with the angiography, right? And so it just really brings home that point that, we've moved on from just trying to treat a lesion, but really vessel preparation, trying to give our patients the best likelihood of having that stent stay patent for the rest of their lives.
Yeah, couldn't agree more. And I think it makes a great point for invasive imaging as well. I mean, it's kind of re-emphasizing that point.
Someone said that we we might do even less if we image more, right? Meaning,
yeah, that's true.
Several cases where you're like, oh, I'm going to have to rota, you image, and it's all adventitial, and it opens up with an NC balloon, and that's it,
Or it's not 360, or it's not as diffuse as you thought. And actually, the real problem is a 5 millimeter area. Even though it looks like 40 millimeters of, pipe on the angiogram, it actually turns out it's eccentric. It's actually small arcs. It's not super thick, and that really helps you choose your device, I think, a lot more specifically for the actual vessel and lesion, as opposed to just kind of what your subjective opinion shows you from the angiogram.
And another thing is that many times the most severe calcification is not at the tightest region in the lesion, right? So you prepare the lesion, but you forget the vessel, adjacent to that region. So it makes total sense to image before and understand the calcification and the entire vessel, as Robert said. So.
Yeah,
when you look at
sorry, that was like the worst thing that is when you've prepped the lesion so well, you're so excited, you put in the stent and the edges of the stents are underexpanded because you just can't see it.
Well, the data supports that, right? When we look at some of the recent studies and there's this idea that we want to look at the MSA at the lesion of interest, but then we have to look at the entirety of the stent. And what we're seeing more and more is that the MSA for the entirety of the stent is not where the focal lesion was that we were treating. It's actually off from that by 5-10 millimeters or so. And again, this goes to that idea, just like what you all were saying, the tightest calcified spot's not even where you think it is. It's off kilter one way or the other, proximal or distal. And you got to make sure that you're able to identify that. And really the only way to do that is with intravascular imaging.
All right, so 2 key takeaways so far is intravascular imaging is key, and we need to be holistic. We need to look at the whole vessel and, treat and optimize the whole vessel. I wanna talk a little bit about nodules. With this being so much research work, kind of better understanding about the various phenotypes. So let's start talking about the phenotypes. Maybe Daniel or Rob, you can take that off, and then treatment approach. How do we approach these different, it's uncommon. We have very high event rates with the nodule. So let's start off with the various phenotypes, Daniel.
Yeah, so nodules are a fun thing. So it's not long ago that nodules were associated with acute coronary syndromes, right? It was third most common phenotype associated with ACS. It was plaque rupture number 1, erosion, and nodules. And as we start treating more complex patients with more comorbidities, more elderly patients, we see more and more calcium. And the more severe, more diffuse calcification we have, the more frequent calcified nodules are. So current literature says that severe calcifications that require prior preparation before going in with stents have calcified nodules in around 20 to 40% of the times. So it's becoming more and more frequent. And what we have learned is that now we have 2 major phenotypes of nodules. One is what we call the eruptive nodule, and the other one is just a calcified nodule. And it's kind of unclear yet if they are a continuum, on the spectrum of the same disease, in the sense that eruptive nodules are just an earlier phase of what it will be a calcified nodule in the future. And the calcified nodules that we see with a smooth surface are harder to dilate. These are more chronic and mature plaque. So this is something that we still need to understand a little bit more. But what we know is that the eruptive nodules, they expand very well. And many times you don't need much aggressive preparation like atherectomy or stuff, just regular non-compliant balloons, 1-to-1 sized. They do the trick very well. And so they get greater stent expansions as compared to the chronic calcified nodules. But when you look at clinical follow-up over time, they are associated as well with very early restenosis, with reprotrusion of the nodules through the stent struts. So again, we don't know exactly what is the cause of that. Maybe an active underlying plaque, maybe that stents are stiffening even more the vessel on hinge points and facilitating that nodule to reprotrude. So we don't know exactly how to manage that situation. What we know so far is that atherectomy versus non-atherectomy doesn't improve the stent expansion of nodules and are not associated with better clinical outcomes. So it's pretty much individualizing treatment and seeing how you deal with balloons and the techniques you have. And last thing I would like to say about nodules is that there is recent evidence also with IVL treatment for calcified nodules. And as opposed to the initial concept that IVL would be effective only in circumferential calcium, now we see that IVL also works in eccentric calcium and calcified nodule regions, providing the same level of stent expansion as non-calcified nodules. But again, it's not about only expanding the stent, but how to deal with these eruptive nodules that come reprotruding, and I don't think we have the answer so far.
So the non-eruptive, they have that fibrous cap. They're much more mature. And as you say, whether you're going to shave them and shock them up front, there's a couple different strategies there. We still are very much working through that. But the eruptive are much more problematic, as you say, because they're the ones, there's something about the base that is problematic because, again, as you noticed, as you already mentioned, we shave the top off, we get a good stent result, everything seems to be okay. It's not the top. There's something about the base. So it's like, think about it, it's like popping a zit. You can pop the zit, but you haven't dealt with anything at the base, the plugged follicle that actually made it happen. There's something there. And there's the idea that possibly with shockwave, with really fracturing a lot of that base and getting that kind of beat up, like taking that, as Ziad will often say, taking a bag of ice and slamming it down and really crunching that up, that may be an effective mechanism to try and keep these eruptives from reprotruding. Again, time will tell. We still certainly have some studies to do in that arena, but we know the other therapies don't work. And so I think that's where really IVL can shine. But again, we really do need some more prospective data there for sure.
Or a combination of both, right? Shaving the surface with atherectomy and really tackling the base with IVL. So this could be ideally a more complete solution. But
yeah, the shave and shock is definitely, a rotoshock, whatever you want to call it, has certainly been advocated for this type of lesion subset. Again, we'll see. It does seem pretty reasonable up to this point.
So we're getting to the we could go on right for now on this topic. So just to wrap up, you end your consensus with a really nice kind of summary of all the clinical studies that are planned, that are ongoing. That Binita, what are the most important trials that we need to be looking out for? I mean, for instance, on this particular topic, I assume that there's going to be some good work coming out that we can be looking out for in the next couple of years.
Yeah, I'm really looking forward to just looking at the strategy, comparing different strategy trials. The trials that are really taking certain lesion subsets and either randomizing them or historically comparing them to one strategy versus another, because I think we just don't have enough data in that area. So that is what I'm most looking forward to, particularly combined with imaging data to sort of separate out the outcomes based on the calcium phenotype. I think that will help us even more, as especially, you know, we talk about precision medicine, that goes for PCI as well, and wanting to be a bit more precise in how to manage the different phenotypes and not just putting calcified lesions all in one basket.
All right. Well, I want to thank you all for joining. This was really, really fun. For our listeners, again, log on to jsky.org, download the paper. It's outstanding. You can learn something from it. And I look forward to our next conversation. Thank you so much.